here. There we are. Okay, so I'm gonna divide this presentation in 3 parts. The first one is gonna be, I'm gonna tell you what are the basic scanning views and how can you do this. So I'm gonna try and explain how to position the transducer within the animal and how to actually get a good image and how does that image need to be. Then the second part is going to be all the measurements that you can do with those scanning views. So we're going to talk about the B mode measurements, the M mode measurements, and then the Doppler color, pulsated wave, and continuous wave. And then the last part is going to be a few clinical cases. I try to condense everything. We only have like an hour and a half, so I condense everything, and I'm only going to talk about the basic stuff. So obviously there are going to be other views that that we can do and other measurements that we can do, but today we're only going to talk about the basic ones. So first of all, we need to position our patient. This is my dog Google, and on the left side you can see we can do it standing, or on the right side you can see we can do it laying down. So differences, well, standing, we are going to be positioned right here on the left side of the animal. Our ultrasound machine is going to be right here. And what we're going to do, we're not going to change positions, either us or the animal. So for the right side, we're going to put our hand or our arm underneath the chest, and we're going to do it from this side. So from the left side, we're going to do it. And then once we finish, we're going to do the left side, just position the transducer on the left side of the dog. Laying down. Let me see if I can minimize this because maybe you can't see it. Hold on. Let's see. Okay, there we are. So on the laying down position, what we need is either we need a table that has a hole in it, so we can put our hand underneath, or we need a table that is going to elevate the dog or the cat in order for us to put our hand underneath. So this is an article, it was published a long time ago. In this article, they talk about the differences between doing an ultrasound or an echocardiogram on a standing position or on a laying down position. They only use 4 healthy dogs, which I think in this case, there weren't too many. But what they found is that the standing position didn't change much with the quality of the images and the quality of the measurements. In my personal experience, I do it laying down, and this is why. Well, first of all, it's faster, and this is only from my personal experience. For me, it's faster because the acoustic window that you have is going to be larger. Obviously, the air is going to go up, and so you're going to have more space to work with. And then also the patient is going to have less movement. So what happens with me when I try to do it standing is that the dog, especially cats, is almost impossible. But with dogs, they start moving a little forward, a little backward. So they're not still. So it takes me longer to do them. Also, in my case, scanning views are more accurate when I do them laying down, especially the right parasternal long axis. And then also, after a few minutes, the patient calms down and the restraining becomes much less necessary. The cons of doing it on a laying down position is, first of all, you have to convince the owner and the veterinarian. This is something that for me is one of those challenges, because first of all, the owner most of the time is like, oh, no, we're not going to be able to do it. He's not going to stay still. And then even the most terrifying chihuahua, you're able to do it. And then the second one is veterinarian. Even the veterinarian is going to say a lot of times, no, we're not going to be able to do that with this dog. So you have to convince them, you have to show them that yes, we can do it. The only time I don't do on a laying down position is when they're in dyspnea, so when they're not breathing okay, when they're very nervous. So once you put them laying down, you're struggling a lot, they're getting very, very stressed out, then you just quit and you're doing a standing position. And then also for some giant breeds, especially Great Danes. Great Danes, I don't even try. I treat them as horses. So again, this is my personal experience. We don't care. No one cares how you do them, how you do the echocardiogram exam, as long as you get good images and good measurements. So how are you going to start? First of all, you're going to start with between the third and the fourth intercostal space. My little tip here is put your hand, trying to find the point of maximal intensity, and that is where you're going to put the probe. And from there, you're going to start switching and trying to find your position. With the feelings heart, remember it's more aligned with the sternum, so you might have to move the probe closer to the sternum. And then just remember, if you're starting and you've done abdominal ultrasound and you're starting to do echo, just remember the movements and rotations are done slowly and slightly. It's not like with the abdominal ultrasound that you can just move and the organ is just going to stay there. The heart moves a lot, obviously it's pumping. So every little rotation, every little movement is going to be done slowly and slightly, or you could lose the entire view. So let's start with the scanning views. The first scanning view that we're going to see, they're going to talk about, is the right parasternal long axis 4-chamber view. So right is on the right side, parasternal, we're going to do it in between the intercostal space. Long axis, it means you're going to see the long view of the ventricle. 4-chamber view. So we're going to have 4 chambers. The right atrium, right ventricle, left ventricle, left atrium. So how are we going to position the transducer? Well, first of all, the marker is going to be at 12 o'clock. So the spine of the animal is here, the head of the animal is here. So the marker is going to be at 12 o'clock, and you have to make an angle of 45 degrees between the thorax of the animal and the transducer. Once you're there, you might have to lift and drop a little bit, maybe rotate a little bit in order to get maximized left ventricle, because this is what you want to get. So this is an optimized image. What you need is the long axis of the ventricle to be perpendicular to the beam. In this case, we have less of an angle. So we don't have a 90-degree angle, we have a little bit less. So when this happens, you're positioned like this. When this happens, you have to lift the tail towards the spine a little bit, and the apex, so you can see here, the apex will drop while you're doing that. Okay, so we're not going to talk about the measurements right now, but once you have an image and you have a view, you can still do, and let's say we can see a lot in that image without doing any measurements. So what are we gonna see? Well, first of all, the right ventricle anterior wall, even though we're not measuring, just by looking at it, the right ventricle anterior wall has to be less than 50% of the left ventricle posterior wall. Okay, so again, not without measuring, you'll get used to seeing a lot of images, and but you'll see how to consider it if it's already thickened or not. Then the tricuspid valve, you're going to see that it's a few millimeters more apical than the mitral valve. Then you're going to see the interventricular septum. You're going to look at it and see if it's displaced, and if it is, during what part of the cycle is, because that is going to give you a lot of information about the right ventricle. The interatrium septum, you're going to see if it's normal, if it's straight, if it's towards the right atrium or towards the left atrium. That is going to tell you also about enlargement of the atriums. Then you're going to see the mitral valve. Is it thickened, like in this case, or is it normal? Is it prolapsed? And then this is something that is going to be very subjective. So you're going to see the left ventricle and the left atrium, are they enlarged? Again, this is something that is going to be subjective, but you can already have an idea once you get this view. So in this case, we have a flattened interventricular septum. This is in telediastole, and you can see here is not straight, is a little bit towards the left ventricle. Here, for example, I put you the measurements here, but just so you get an idea, the right ventricular anterior wall is more or less the same as the left ventricle posterior wall. So you can see the measurements here is almost 4 millimeters, and this one and almost 5. So they're more or less the same. It should be less than 2.5. Okay, so you can already have an idea of that. Here we have a normal mitral valve, it's thin, and we have a thickened mitral valve, so you can see it right there. This is the image of a cat. This is in Sicily, but I wanted you to see a little bit the differences. Even though it's going to be harder for you to get a good image, a good parasternal long axis for view, especially a good perpendicular angle, you can still do it. You can see it here. It's pretty good. It's not the useful thing, but you can still do it. So really try hard to do it. Okay, now we're gonna go to the right parasternal long axis, but in this case, 5-chamber view. That is the left ventricular outflow view. So what it means is that we're gonna see the outflow tract, which is the aorta here. So we're gonna have the left ventricle here, mitral valve, left atrium, aorta, interventricular septum, right ventricle, tricuspid valve, right atrium. How are we going to do this? So starting from the long axis 4-chamber, which was, the marker was at 12 o'clock, we're going to rotate a little bit counterclockwise in order to put it at 11 o'clock. And you don't have to move anything. So don't tilt, move, or drop the transducer. It's just going to pop out. So once you rotate a little bit, you're going to see this. So what can we see in this view? What we're going to see the aortic valve. We're going to see if it's normal, is it thickened, and then we're going to see if there are any abnormal complications. Usually, especially in cats, we're going to find them right here. Those are obviously the ventricoseptal defects. Okay, now we're going to go to the short axis, left ventricle view. So in this case, this is the left ventricle. We call it the mushroom view, right? Because it looks like a mushroom. So this is the left ventricle, interventricular septum, right ventricle. So with the transducer, we started at 12 o'clock, then we rotated a little bit to 11 o'clock. So now what we're going to do is we're going to rotate a little bit more in order to be at 9 o'clock, so perpendicular to where we started, again, counterclockwise. And once we're there, we're gonna optimize the view by fanning the tail. So we're gonna go towards the spine or the sternum in order to go apical or more to the heart base. That way, you're gonna optimize. If you wanna see the apex, you're gonna tilt the tail towards the spine. If you wanna see more of the mitral valve, so more towards the heart base of the heart, sorry, the heart base. Then you're gonna put the tail, bring it towards the sternum. Okay, so what can we see without doing any measurements? What can we see? So we're gonna see, is the chamber symmetrical? Are the papillary muscles, which are right here, are they similar to each other? Is the interventricular septum flattened? We can also see it here. Well, sometimes you can see it right there. And it's a contraction. Obviously, I didn't put a video to avoid connection problems, but you can see if the contraction is uniform. And then also here, you can see the right ventricle anterior wall, which is this one. You can compare it to the left ventricle posterior wall, which is this one. In a cat, in this case, we have a very good image. A lot of times, especially with HCM, so with hypertrophic cardiomyopathy, you're gonna have a very small left ventricle. So you might not get such a good image, but you can still get it. The angle is probably gonna be more towards the left side. So usually on the dog, we have it more towards here. In the cat, we have it more towards the left side. Okay, then we move a little bit towards the heart base, and we're going to see the mitral valve. With the mitral valve, which is this, and this is we call the fish mouth, right? Because it looks like a fish opening and closing its mouth. And we're going to see the valve movement. We're going to see if they're symmetric valves, and obviously we're going to see if they're thickened. Okay, then we move towards the heart base, and we're gonna get the left atrium aorta view. So to get a good image, we need to see the aortic valve right there. And we need to see the left article, because that way we know that we're maximizing the size of the left atrium. So we're still gonna be at 9 o'clock. The marker is gonna be at 9 o'clock. But as before, as I was telling you before, we're gonna tilt the tail away from the table or towards the sternum. So we're gonna tilt it, and that way we're gonna see it. And once we're there, we're gonna optimizing by rotating a little until we see the left article popping out. This is the same thing in a cat. A lot of times you don't get such a good image, but again, try, because cats, I know it's that fear of doing a cat, you can still get good images, so just do a lot of them, and you'll just get the hand to do it. Okay, then we're gonna be always with a heart base, always in short axis, but now we're gonna concentrate on the right ventricle, outflow tract, and pulmonary artery view. So always at 9 o'clock, the marker, what we're gonna do is we're gonna tilt the tail away from the table. So you're still gonna tilt it a little bit towards the sternum, but in this case, you may need to move the transducer one space caudally. So you move the transducer caudally one space, and then once you're there, you might have to, move it. So not tilt it, just move it away from the spine. So always towards the sternum. So you tilt the tail, you move one intercostal space, and then you move the transducer a little bit. Moving the transducer is going to allow you to have an angle that is going to be more aligned with the beam. That way, obviously, you're going to see a good image of the valve. But that way, once we do the measurements with the pulsated wave or the continuous wave, we're going to be more aligned. As you can see here, this is the pulmonary valve, pulmonary artery, right main pulmonary artery, and this is going to be the left one. Obviously, right ventricle, tricuspid valve, right atrium. Okay, so what can we see here? We're going to see, obviously, the pulmonary valve. Is it symmetric? Is it, does it have normal valves? Normal valve leaflets, and does it have a normal movement? Do we have any post-stenotic dilation? You're going to see it right there, if there is. And then we're going to see, are there any thrombos, especially here and here? Are going to be any thrombos? Or Durfilaria, which is heartworm, are we going to see them? Usually we see them right here. And then you might find some tumors, so those are masses, like for example, chemotectoma, you can find them right here or here. This is Durfilaria, so this is heartworm. This is how you're gonna see it. I always recommend for you, even though this was a positive case, so I was already kind of having an eye to try and find them, but I have to say, I have found them in dogs that they didn't do any tests. So always make sure that you see that you take a look at the bifurcation, because you might find some not so grateful surprises. So with the heartworm, you're going to see two hyperechoic lines parallel to each other. So like the railway view. Okay, now the subcostal. The subcostal view, it's something that not a lot of examiners do. When you're doing in a standing position, for me, it's very, very difficult to do it. I try to do it in almost all the dogs and cats. I don't do it, but on almost all the dogs, I try to do it. And I'll explain why, but how you do it. So you're going to put the transducer, obviously, it's not going to be personal. So you're going to go underneath the thorax. So this is hyphoid. You're going to go underneath. The marker is going to be towards the spine. So the spine of the dog is here. The head of the dog is here. And you're going to place the marker towards the spine. And you're going to place the transducer as parallel to the spine as possible. So this is the view. This is the aorta, left atrium, mitral valve, left ventricle, right ventricle. And this is why, because once we have it here, we're going to be much more aligned to get pulsated wave and continuous wave measurements. So in order to get obviously the positive or the aortic flow, we're going to be more aligned. And also when we have an insufficiency, we're also going to be more aligned. So I try to do it in every dog. Okay, then we move to the left side. So we're going to be in the left parasternal apical 4-chamber view. Okay, 4-chamber, 1, 2, 3, 4. Mitral valve, tricuspid valve. So how are we going to do it? We're going to place a transducer with a 30 degree. So the thorax is here. The transducer has to have a 30 degree. And the marker is always going to be towards the spine. So here's the spine of the dog. You're going to place a marker towards the spine. So most of the times you're going to get this image. So with this image, it's okay. But the thing is, with a lot of measurements, is not the optimal view. So what we're going to do is we need to have the long axis of the left ventricle has to be parallel to the beam. So what we're going to do, we're going to move the transducer towards the sternum. So you have this view. You move the transducer towards the sternum. Again, not tilting, just moving it. And that is going to make that the apex goes to the right side. And you're going to get this view. So what are we going to see here? Well, we're going to see the valve movement, obviously. We're going to see the mitral valve appearance. So is it thickened? Is it prolapsed? As in here, you can see that it's a little bit prolapsed. The anterior leaflet. Is it dysplasic? Then we're going to see the tricuspid valve. Is it dysplasic also? So is it how is its position compared to the mitral valve? It has to be a few millimeters, but when you have it here, you know, it might be a tricuspid dysplasia. And then always subjective, we're going to check the left of the chamber. So we're going to check the left ventricle, the left atrium, the right ventricle, and the right atrium. Then we're going to move to the 5-chamber view. So how are we going to move? Again, not moving anything first. The marker was here towards the spine. We're going to rotate the transducer counterclockwise until the aorta appears. So you just, again, very, very slight moves. You rotate it a little bit, and then it pops out the aorta. Once you have it, you might have it, especially with cats, you might have it right here. So you're not going to get a good angle. This is why I usually do the subcostal. So in order to get a better angle, what you have to do is you have to tilt the tail away from the table. So towards the sternum, you're just going to tilt it to align the aorta to the beam. Again, aorta, left atrium, mitral valve, left ventricle, right ventricle. What we're going to do here, well, more or less the same as we did with the subcostal. So we're going to see the valve movement and the anatomy. So do we see any changes? Okay, and then last but not least, we're going to do the left parasternal apical optimized for the tricuspid valve. So this is something that not a lot of people are used to do. I strongly recommend it because you're going to get a good image of the tricuspid valve. And also, we'll explain later, also you can, you're going to get a lot of images in order to, let's say, do measurements for the right ventricle. So from the apical 4-chamber view, you move the tail towards the spine. So you tilt it a little bit towards the spine. You move one intercostal space cranially, and then you rotate the transducer counterclockwise. It seems like a lot of stuff, but once you get the hand, it's not so much. So tilt the tail, move one intercostal space, and then rotate a little bit until you get a good image of the tricuspid valve. Like here, for example, you have a good image. The angle, obviously, you're tilting the tail towards the spine. So obviously, the angle is not going to be as parallel as with the apical 4-chamber view. But we need to see this part, so this doesn't matter. But you can see here, this was a prolapse tricuspid valve. So it's very good that you get a good image of this area. Also, with the with the tricuspid regurgitations, you're going to be more aligned also to get a good wave. Okay, now we're going to start with the measurements. So right parasternal long axis view, obviously the 4-chamber long axis view. So With the B mode, we're going to measure the mitral annulus, the left atrium width, the ejection fraction with the Simpson method, and the ventricular wall thickness. With the M mode, I'm going to explain it, so don't worry. With the M mode, we're going to do the E-point septal separation. With the collar Doppler, we're going to see mitral regurgitation or any abnormal communications like ventricular septal defects or atrial septal defects. And then with the continuous wave, if there are any abnormal communications, we can measure them. So the mitral annulus. So what we're going to do is we're going to draw a line from hinge point to hinge point of the mitral valve. That is going to be a measurement. And you can see here, there's an article that explains very good. It's been published in the last few years. And it explains that they came out with some normal reference range. And what we're going to do is we're going to measure the mitral annulus in diastole, which is in end diastole, in systole, which is going to be in end systole. You can see here for the diastole, it's going to be the first frame after the mitral valve closure. And then for the systole, it's going to be the last frame prior to the mitral valve opening. So both of them are going to be the mitral valve closed. The first one is, end diastole is going to be the first frame right after the mitral valve closed. And is closed, and the systole is going to be right before the mitral valve is open. Then what they discover with this article is the conclusions are that when we have a more advanced myxomatous mitral valve disease, the mitral annulus was increased. So this is a good way to stage and see if we find out if we have a more advanced disease. With the B mode also, we're going to do the ejection fraction. I'm not going to explain the Simpson mode here. Sorry, the Simpson method here. I'm going to explain it with the apical view, but just so you know, we have to also do it with this view. Okay, then the left atrium width. So what we're going to measure here, you can also hear, you can also read this article. It's also been published in the last few years, and it's a ratio that we can do complementing the usual one that we do with the left atrium aorta of the short axis heart-based view. And again, it's to complement both the other ones, so you get both of them. So what you're going to do is you're going to draw a line. You're going to obviously be in this view. You're going to draw a line that is going to bisect the atrium. It's going to be in end diastole. So again, 1 or 2 frames right before the opening of the mitral valve, sorry, end systole, and because that's where we're gonna have the maximum size of the left atrium. So end systole, we see when the mitral valve is opening, then we go back a little bit, 1 or 2 frames right before, and we draw a line that is gonna go from mid-atrial septum to the pericardial echo. You're just gonna draw a line, you're gonna measure it. It's going to be roughly parallel to the mitral annulus, okay? So you can imaginary see the mitral annulus, draw a line. And with this measurement, you're going to do a ratio with the aorta. I'm going to explain what measurement of the aorta afterwards, but just so you know, with this measurement, it's going to be the normal dial is going to be between 1.8 and 2.4. This, again, is to complement because with the regular short axis heart-based view, a lot of times you get some error. So subjectively, you see it and you see that we have an enlarged atrium, and then you see it and yeah, it's not so large as you thought. Well, when you do this one too, you're going to complement and you're going to see, well, and this one is much larger, so maybe the other one, it was underestimated. Also, obviously, as we were talking before, where you're going to measure the right ventricular anterior wall, and you're going to compare it to the left ventricular posterior wall. As I said before, it has to be less than 50%. Okay, so the E-point septal separation, what we're going to do is with the beam, with the M-mode beam or M-mode line, we're going to go at the level, at the tip of the cranial mitral leaflet, so right there. And then with the M-mode, you're going to measure the distance between the leaflet and the interventricular septum. The EPSS has to be less than 6.5 millimeters. This article explains very good how you should do it. And it was done in Doberman Pinschers, which is obviously a breed that we really want to make sure that they don't have DCM. So obviously, collar Doppler, we're going to see mitral regurgitation. We can have a semi-quantitative evaluation. This is obviously subjective. Then we can have collar Doppler and continuous wave of any abnormal communications that we might have here. Okay, the long axis 5-chamber view, so the left ventricular outflow view. With the beam mode, we're gonna measure the aortic diameter. Then we're gonna measure the aortic diameter for that ratio that I was telling you before. We're also gonna measure the interventricular septum and left ventricle posterior wall thickness, especially for cats. Collar Doppler, we're gonna see if there's any aortic insufficiency, if there are any abnormal communications, if there's an outflow obstruction, like for example with systolic anterior movement with HCM in cats, or if it's a turbulent flow. We're also gonna measure with a continuous wave of any abnormal communications that we find. So the aortic diameter, as with the mitral valve, hinge point to hinge point of the aortic valve. Okay, so for the ratio I was telling you before with the left atrium width, what we're gonna do is you're gonna measure the distance between the leaflets at the point where the aortic valve is open, so it has the maximum diameter. And this is gonna be, as you can see here, an early systole, okay? And you're gonna measure it. You're not gonna include the Valsalva sinus. In this case, with the interior leaflet, you might have to, just because you can't see it here, but especially in this, you have to make sure that you're with the aortic leaflet and not including the Valsalva sinus. This is what happens also with the short axis heart-based view, is that a lot of times we consider those, so we're overestimating the aorta, so the ratio gets lower. Okay, so we're going to measure also the interventricular septum and left ventricle posterior wall thickness, especially in cats. We consider hypertrophy when it's over 6 millimeters, but be careful because some breeds are not considered let's say like the limit is not considered 6 millimeters. It can be considered 5 millimeters, like for example with Sphinx cats. So be careful with some breeds. This is another article that you can read, and it's very, very good explaining how to do the measurements. And but I'm gonna try and go over it. So what you're gonna do, you're gonna make 4 different measurements all along the wall. So 1, 2, 3, 4, 1, 2, 3, 4. In order to consider a left ventricle hypertrophy, you have to have the hypertrophic area has to be more than 50% of the wall. So yes, you can have an area, sorry, hypertrophic area, but in order to consider left ventricular hypertrophy, you have to have more than 50%, sorry. Okay. So you're also gonna see if that hypertrophy is gonna be symmetric or is it gonna be asymmetric. And then once you have a left ventricular hypertrophy, you're gonna have to exclude hypertension, dehydration, and hyperthyroidism. So obviously, some of them you can exclude right away. With dehydration, you have the animal in front of you, so you can just see it. But with hypertension and hyperthyroidism, you have to ask the veterinarian to do some other stuff. So a lot of times you can't give a diagnosis right away. You have to put in your report, this is compatible with, for example, HCM or hypertension or hyperthyroidism. Okay, so with the collar Doppler, you're gonna see also if there's any aortic insufficiency or if there are any abnormal communication. So you can see, I put also the normal B mode, so you can see this is the ventricoseptal defect right here. This was a cat. And you can see with the collar Doppler right here, the turbulent flow right over there. Also, we can see if there's any outflow obstruction, like with SAM, systolic anterior movement, or like in this case, if there's a turbulent flow. So for example, like with subaortic stenosis. Okay, the right short axis left ventricle view. So in this case, we're gonna do the M mode. So this is how it should be. So the MO line is gonna bisect the left ventricle. This is a cat, this is a dog. It's gonna bisect the left ventricle. You have to be able to see the pericardium, and you have to be able to see the right ventricle. So I wanted you to see the difference between cat and dog. Again, cats, when you have hypertrophic or a very high heartbeat, you're not gonna see it this good. You're gonna see it very, very fast, and the left ventricle chamber is not gonna be as good as here. But again, when you have a normal cat, you can definitely get good images. You can see this would be not the best one because you can only see a little bit of the right ventricle. Here you can see also a little bit, but here would be this would be the best. So right ventricle, interventricular septum, we bisect left ventricle into 2 equal parts, and we see the pericardium, and we're able to see a good chamber, a good interventricular septum. That way you can do all the measurements. Okay, so how are we gonna do the measurements? Well, with this, what you have to kind of like keep in mind. When you measure the walls, you're gonna include the lines. That means that, as you can see the arrow here, so we're gonna measure the interventricular septum. So we're gonna place a cursor right before the line because we wanna include the line in the measurement, and right after the line here. Instead, when we do the chambers, we don't include the lines because we're measuring actually the chamber and not part of the wall. So we place the marker or the cursor right before the line. So diastolic measurements, we're gonna do at the onset of the QRS, usually. And this is where we have the maximum size of the left ventricle. Then we're gonna, this is why it's also very important to have an ECG, because that way you're gonna make sure that we're in telediastole. And then for the systolic, we're gonna do the same thing right after the T wave, right there. So again, please make sure that you have an ECG on your ultrasound machine, because it's gonna help you so much. Okay, you can also do the EPSS here. So what you do is you do the mitral valve view. So you tilt a little bit the tail towards the heart base. Once we see the mitral valve, so the fish opening and closing its mouth, then we do the M mode, and you're gonna see this is the mitral valve. This is obviously the interventricular septum. So you're gonna measure the distance between the mitral valve at its highest point and the interventricular septum. Okay, so I was telling you before, with the short axis, heart base, left atrium aorta view, we do obviously that you all know, the left atrium aorta ratio. So this is the article that explains how to do it. It was, as you can see, it's from 2000, it was 20 years ago. But we still do it nowadays. So this is the non-coronary cusp, right coronary cusp, left coronary cusp. It's very important that, as I was telling you before, that you see the leaflets in the view. And what you do is you're gonna draw a line, so you can see here, along the commissure between the non-coronary and the right coronary. You're gonna draw a line following the commissure right up to here. And then in this, this is gonna be the frame, as I was telling you, where right after the closure of the aortic valve. And as you can see here, first frame after the aortic valve closure. And then for the left atrium, what you're gonna do is you're gonna follow the commissure between the non-coronary and the left coronary. So you're gonna follow the commissure, and parallel to it, you're just gonna draw a line. Just be careful, because here, this is the vein, this is the pulmonary veins. So you don't want to include them because if not, you would be overestimating the size of the left atrium. So in this case, we have the wall, but if you can't see the wall, what you do is you draw an imaginary line. It has to be curved, so it can't be straight. You have to follow like that. You have to follow the, what it would be the wall of the left atrium. Okay, so just make sure that you don't include the pulmonary vein. Okay, then in cats, you can also do M mode. The thing is with the M mode is a lot of times we don't bisect the atrium so good. So for example, as you can see here, you're not bisecting the atrium so good. So you're not getting the maximum size. In this case, it was good. It was a good, it was a good image. With Mindray, we have say a feature that it's the free X cross, and it helps a lot. What it is, the free X cross, is that when you have the M mode, you can only move one part of the beam, right, of the line. So this part is fixed, and you just move it like that. So you're working with an angle. That's why a lot of times we can't. So if I moved it over here, yes, I could bisect the atrium better, but then I wouldn't get the aorta. So with the free X cross, what we do is we can do whatever we want with this line. So we can move it right, like here, from here to here, and we can manage the angle as wherever we want. So in this case, I was able to get a good M mode. Okay, then with RVOT, so with right ventricular outflow tract and pulmonary artery view, with B mode, we're gonna see the pulmonary valve and we're gonna measure the diameter. With the color flow, we're gonna see if there's any insufficiency, if there's a turbulence, so if there's a turbulent flow, and also if there's a PDA, a patent duct arterius, so an abnormal communication. Then with the pulsating wave, we're gonna measure the flow of the RVOT, and then with the continuous wave, we're going to measure if there's any insufficiency or if the flow is turbulent and not laminar. Okay, pulmonary valve diameter, hinge point to hinge point, right there. Color flow Doppler, insufficiency right here. A lot of times you can see it even here because obviously we're not looking at a line. It's a plane, so sometimes you can have it here or here. A turbulent flow, like for example with pulmonary stenosis, and a PDA. So this is the area where you want to look for a PDA. So this is a pulmonary valve, pulmonary artery. These are the right and left main pulmonary arteries. So right here is where you want to check for the abnormal flow. Right over here. A lot of times what you do is when you place the color flow here, you see a jet coming in. And that way you kind of like, oh, what's that? And you go down and you actually see it here. There's also another view that you can check it, but again, we're today we're only talking about the basic views. Okay, so pulsating wave. So we're going to do a pulsating wave of right ventricular outflow tract. So we place a cursor at the pulmonary valve, and we're going to follow with a line, we're going to follow the external edge from baseline to baseline. Again, following the external edge. It has, in the pulmonary valve, has to be rounded, a rounded wave compared to the aortic flow. This is important for you to know because if you don't have a rounded, this is more rounded, you'll see the aortic flow later. If you don't have a rounded one, it might mean that you might have pulmonary hypertension. Okay, so always try and not only measure it, but also look at it. Okay, with the continuous wave, we're gonna measure the insufficiency here. A lot of times you don't get like a very, very good image of the insufficiency, but you wanna get the maximum. Also with the continuous wave, we can measure turbulent flow, for example, in pulmonary stenosis, as you can see here, right over there, because for us it's very important to measure the maximum velocity. Okay, subcostal view. Again, this is something that is very useful for aortic insufficiency that you can measure with the color Doppler. And then with the pulsating wave, we're gonna measure the flow of the aortic flow. And if there's any insufficiency with the continuous wave, we're gonna also measure it. So here you have an insufficiency. This is a very tiny insufficiency, but still is easy for us to measure it from here. As you can see, we have a very good angle. Okay, so remember the one for with the wave for the pulmonary flow? It was much rounder. You can see here is sharper. So this is what an aortic flow has to look like. This is a laminar flow. We can use the continuous wave when we have either a high velocity, so we have a laminar flow, but it's not enough with our pulsated wave to get the maximum velocity. So then we use continuous wave just to get the maximum velocity, or when we have a turbulent flow. And then we can do an aortic insufficiency, as you can see right here. Okay, then we go to the left parasternal apical four-chamber view. So with the B mode, we're going to do the Simpson method that we're going to explain right now. With the color Doppler, we're going to see any mitral regurgitation. With the pulsated wave, we're going to measure the transmitral filling pattern. And then with the continuous wave, we're going to measure the mitral regurgitation. So let's start. Okay, the Simpson method. So we're going to get two images. I always recommend when you're doing an echo, get all the images, even though you don't have to do all the measurements, get all the images and videos, because maybe in the future you want to do a measurement. So always get all the measurements and videos, especially videos. So once you do, for example, the right parasternal long axis view, take a video. I recommend not of one or two, I recommend like 4 or 5 heartbeats in one video, because that way you can see, especially when we have, for example, sinus arrhythmia. So 4 or 5 beats, take a, it's probably like maybe like 4 or 5 seconds video. Then take images, obviously take pictures, but with the apical view, we're gonna do the same thing. So you get a video of a long, I would say like a long video, because that way you can make sure that you get the best image that you can. So we're going to measure 2 different images. One of them is going to be in end diastole. So as we've been saying all the way through the presentation, it's going to be more or less at the QRS onset. Sometimes a little bit after, as you can see here, in this case, it was right after the R wave, so at the end of the R wave. What you want to make sure is that mitral valve is closed and we have the largest volume, so they have the largest size. Then with the systole, we're going to do the end systole, and it's going to be the frame before the mitral valve opening, which is usually after the T wave. Okay, so what we're going to do with the Mindray, you can either do the automatic or the manual one. So with the automatic method, or you're going to do is you're going to draw the line with the base, so the mitral annulus right there. Then you're going to draw a line of the maximum length of the left ventricle, and then automatically it's going to tell you what is the area. But then you have a little hand that you can correct a little bit, because obviously it's not perfect, but I have to say it's pretty good. So you might have to correct it a little bit in order to follow all of the endocardium. Same thing with this systolic one. With the manual one, what you do is you just follow the endocardium all the way, left ventricle and mitral valve. And then it's just gonna calculate the area by itself. Okay, so here you have 2 good articles about the Simpson method. And this is in 2 breeds that are, it's very important to do the Simpson method. I don't do it with all the dogs, I have to say. I usually do it when you are so sure the volumes that you get with the mode are accurate, or especially with dogs that are, you want to make sure that you have a good measurement of the ejection fraction. So this is an article about boxers, so it's going to give you breed-specific reference ranges. And this is a very good article about the guidelines for dilated cardiomyopathy and for screening guidelines for dilated cardiomyopathy in Dobermans. Okay, so and diastolic ventricular index. So this is index to the body surface area. The normal ones are going to be between 49 and 93. And the end systolic ventricular index, volume index is going to be between 22 and 50. So these are the normal ranges. In Dobermans, from this article, we can see that the end diastolic volume index, again, to body surface area, is going to be less than 95. And the end systolic volume index is going to be less than 55. If we have something over these ranges, then indicates occult DCM. So even though you don't have anything else, you just have this, it indicates occult DCM. So take a look at this article because it's very good. There's something that I forgot to tell you, but what we have to do is, I was telling you before, we have to measure both. So we have to measure in right parasternal long axis view and apical view. We do the Simpson method in both, and we use the largest volume. Okay, then we do with the collar Doppler, we're gonna see the mitral regurgitation. So in order to, let's say, measure the regurgitation, there are very different ways, and I have to say they're a little bit complicated and long. So a way that we can use that is easy and very fast, it obviously has more errors, obviously, because it's very subjective, but what we can do is we can measure a ratio between the regurgitant jet area signal, which is going to be this, and the left atrium area, which is going to be this. So as you can see here, this is going to be the regurgitant jet area signal. So you have to compare this to the whole area. If it's less than 30%, we have a mild regurgitation. If it's between 30 and 70%, we have a moderate. If it's over 70%, we have a severe regurgitation. Again, this is something subjective. You have to make sure that you get a good image of the whole jet. And in this case, for me, it would be a moderate. We're all almost close to severe, but for me, I would say that this is kind of like a 2/3, so it's 60%, so it's still moderate. Then we're going to do the transmitral filling pattern, or diastolic filling pattern is the same thing. What we're going to do is we're going to place the cursor, so the two lines, we're going to place them right where the tips of the mitral leaflets are in early diastole, okay? So we're going to place it here. So don't place it where the mitral valve is, place it where the tips are. This is where you're going to get. You're going to get this type of wave, or this, or this, or this. Or these are the four patterns that you can get. The normal pattern, the ratio between E and A, which once you measure it, the machine is going to automatically calculate it for you. So it's going to be over 1. The deceleration time is going to be of the E wave. It's going to be between 52 and 108 milliseconds. When we have an impaired relaxation, for example, when we have either HCM or, for example, systemic hypertension, we are going to have the EA ratio. It's going to be less than 1, so it's going to be the opposite. The deceleration time is going to be normal. With pseudonormal, we're going to have the EA is going to be the same thing as normal. It's going to be over 1. The deceleration time is going to be either normal or decreased. So you're going to ask yourself, so how can we differentiate between these two? You might have to do the tisular Doppler. And then with the restricted filling, we're going to have the EA is going to be way over 1, usually I consider 2. And the deceleration time is going to be lower, so it's going to be lower than 52. So E wave goes for early filling, right? So it's going to be between the T wave and the P wave. Very important that you get an ECG, because if not, for example, when you have a sinus arrhythmia, you're not going to know, or when we have a very fast heartbeat, you're not going to know which one is the E, which one is the A, and you might just confuse an impaired relaxation with a pseudonormal or the opposite. So always try and get an ECG. Then you can also do the TDI, obviously the tisular Doppler. But yeah, so the E wave is going to be between the T wave and the P wave. The A wave is going to be more or less at the onset of the QRS, so right there. When we have a very increased heartbeat, the waves can be fused, so you're not going to be able to differentiate both waves. So in this case, diastolic filling pattern is not going to be accurate. This is, for example, we have a dog, it's 180 and 82 beats per minute, and you can see here, and you can follow with the QRS, you can see here, okay, maybe this is the E, but what about the A? We can't see it very good. What I did, this is the same dog, what I did is I just waited a few minutes, not long, I may just be doing other stuff with that, but then I remeasure it again. Now we went down to 157, and you can see that now we can have the two waves. So be patient. It's just going to take maybe 1 or 2 minutes longer, but that way you're going to have a good filling pattern. Okay, then with the continuous wave, we're going to measure the mitral regurgitation. So what we're going to do is we're going to align the line of the continuous wave line. We're going to align it with the regurgitation. Now we have also this little angle that you can also move. That is going to help you a lot. So you can also move it like this, and you have to align it, because a lot of times we don't usually have a central. If it's severe, we might have a central. If it's a mild, for example, with dilated cardiomyopathy, we might have it also central. But a lot of times we have it either posterior or anterior. So you have to align it, align very good. The mitral regurgitation should be between 5 and 6, the velocity should be between 5 and 6 meters per second. And this is why. So these are the normal systolic pressures in the heart. And we're gonna have here, the left ventricle is gonna have a systolic pressure normally of 120. This is gonna be the same one as the aorta. And the mitral regurgitation is gonna be the difference between these two pressures. So if we have a mitral regurgitation that is way over 6, so closer to 7, we might be looking at systemic hypertension. So when you have a very high mitral regurgitation, always recommend to do a blood pressure. When we have it on the other way, when you have it way over or lower than 4 or 5 meters per second, you have to do 2 things. First of all, you have to try and align better, just to make sure that you're getting a good wave, that you're getting most of it. Another tip is when you're using the either the pediatric maybe not, but the neonatal one, the neonatal probe. So a probe that is high frequency, for example, with cats or with small dogs. With very, very high velocities, you're not going to be able to measure it. So with regurgitations, if you see that you're not able to get a good wave, so this type of wave, then change probe and switch to a probe that is a lower frequency. If after you do that, you still get a low velocity, then you might be looking at systemic hypertension. Okay, the 5-chamber view. So these are the same measurements that we could do with the subcostal view. So if you haven't already done it with the subcostal view, you can do it here. Obviously, pulsating wave or continuous wave of the aortic valve. And then if there's any aortic insufficiency, you can do it with the collar and with continuous wave. Here you can see a little aortic insufficiency, but as you can see, the beam is not as good as the other one. And here we're measuring that insufficiency. Okay, we move to the left side. So left parasternal apical optimized, sorry, we will go to the right side. So left parasternal apical optimized for tricuspid valve. So we're gonna concentrate ourselves in the right side of the heart. With the collar Doppler, we are gonna see if there's any tricuspid regurgitation. Make sure that the little area that you put for the collar Doppler is not too big, because here is the aorta. So a lot of times you have a very big square, kind of like very big area, you might get the flow of the aortic flow, and you might think that that is a regurgitation, and it's not. So make sure that you restringe the area to the tricuspid valve right here. Also, we can do the M mode, the TAPSE, which is a new, also another, I'll explain to you later, another measurement. And with a continuous wave, we're going to measure the tricuspid regurgitation. Okay, so with the color Doppler, we can also do the same evaluation of the regurgitation as we did before, but it's going to be harder to evaluate because we have more errors. So you can say mild, moderate, but it's not going to be as accurate, let's say, as the other one. The TAPSE. So I'm not going to go over the TAPSE. So it's a tricuspid annular plane systolic excursion. So what it is, it's a measure. It's a ratio, is it like that? That is going to provide you with a number that is going to help you measure the right ventricular systolic function. So now we're concentrating. Now the new articles are concentrating a lot of the function of the right ventricle. And because we didn't have a lot of measurements with that. So this is a new thing. What you're going to do is you're going to do the M mode at this side right here. And then like with the EPSS, more or less, you're going to measure the excursion of the tricuspid leaflet with the right ventricular anterior wall. So again, these are the two articles. They're going to talk about it. Try and read them. This one is from 2012. This one is a little bit, I think a little later on. Okay, and then the continuous wave. We're going to measure the tricuspid regurgitation. Same thing as with the mitral regurgitation. So we have to align very good. And in this case, it's very, very important because most of the times we're going to have a regurgitation that is going to be posterior. So the direction is going to be towards the outside of part of the heart. And that a lot of times is not going to, when it's anterior, it's very hard to align. But when it's posterior also, you're going to have to optimize the view to be aligned very, very good. And just make sure that you get, when you have the feeling that you're going to be getting high velocity switch probes. Even though you lose the quality of the image, you're going to gain the quality of the Doppler, and that is going to be obviously is going to switch from being a normal dog with a tricuspid regurgitation or a dog that it could eventually have pulmonary hypertension. So when it's over 35 millimeters of mercury at the pressure, it can suggest pulmonary hypertension. So it's not a diagnosis, it can suggest it. So look for other signs, like for example, hypertrophic right ventricular, the interventricular septum that is flattened. So look for those. Okay, and then clinical cases. So I put two. I think we're good with the time. So Luna here, she's a mixed breed dog. She weighs 12 kgs, but she's overweight, and she's 11 years old. So in June of 2019, she came in for her first echo after they noticed a heart murmur, and obviously we diagnosed her with myxomatous mitral valve disease. She had a mild left ventricular enlargement. The normalized left ventricle internal diameter in diastole, it was 1.8. So we recommended pymobenzin, which they never started. So after 6 months, in January 2010, she comes in for a recheck, which is great. And this is what we find. So left ventricle doesn't seem pretty big. The aortic flow seems laminar. With the M mode, it doesn't seem, again, this is something that is subjective, right? It doesn't seem very, let's say, very enlarged. But, well, actually, the aorta and left atrium aorta ratio, it was a little bit over. You can see sometimes I do it like that. It's the same thing as doing it the other way. There was another article that it says that there's no difference between doing both. So you can see that sometimes I do it like this. And then the mitral regurgitation, yeah, it was a moderate, so it was okay. But this is what happens. With the subcostal, we have, it was laminar, but we have a very high velocity flow. So in this case, it was over 2, usually up to 1.5 would be okay, but this was over 2. And the mitral regurgitation, in this case, it was around 7. So it was pretty high. So being an overweighted dog, I just said, let's just take a look at the adrenal glands. And the adrenal glands, the left one was normal. The right one was a little bit enlarged. So our plan was I recommended measuring the blood pressure, recommended blood work, and I recommended a complete abdominal ultrasound. So with the blood work, it showed elevated liver enzymes. The blood pressure showed systemic hypertension. It showed 200 systolic arterial pressure. And then the abdominal ultrasound showed enlarged right adrenal gland and the liver. So they did the ACTH stimulation test, and it was in the gray zone. Also, seeing that it was in the gray zone, we said, let's measure the water intake, and it was normal as for the owner. So we didn't start any treatment for Cushing's disease because we didn't have a diagnosis of Cushing's disease. But we started treatment for obviously for the high blood pressure. We started amlodipine. The thing is that we're still not able to control it. We have lowered down to 180. Then we changed the dose. But a few weeks ago, I did it again. It was still 187. So now the plan is, first of all, repeat the blood work to see if anything has changed. Because right now we're June, it's been 6 months. We're gonna repeat the ACTH test, maybe do a low dose dexamethasone stimulation test. We're gonna recheck the ultrasound, the abdominal ultrasound, maybe do a contrast and haze ultrasound of the right adrenal gland to see if it's maybe a pheochromocytome and it's not Cushing's disease. And I also recommended to recheck echo, so we'll see. The thing that you have to take home of this is that without the echo, we would not have been able to find hypertension because there were no clinical signs as per now. Obviously, later on, we'd find it out maybe because she would be blind, or maybe because she would start drinking a lot because she had kidney disease. So it's very important that we do all the measurements, because a lot of times we find out things, not very surprising things, but it's very important that we do all the measurements. And then clinical case number 2 is evil. Yes, her name was evil. She wasn't as evil, but she wasn't also an angel. She is a Sphynx cat. She's a female and she's 10 months old. So they called me for a breed screening, and they wanted to make sure that she didn't have HCM. And the thing is that they thought that she was pregnant because she had like a big abdomen. There were no murmurs during the auscultation. So this is what we found. Well, I didn't find HCM. It was 4.8 millimeters, and Sphynx is up to 5. So she didn't have HCM. And I have to say, most of the rest of the echo was almost normal. But what we can find here, 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 and here is an ventricoseptal defect. So again, this cat was complete normal, and she didn't have any murmurs or anything like that. So I checked her abdomen, just praying that she wasn't pregnant, obviously, and she wasn't. What she had was some content, liquid content in her uterus, either a pyometra, hydrometra, hemometra. So what we recommended spaying as soon as possible for 2 reasons. First of all, because she couldn't breed. Obviously, with a congenital defect, it wasn't recommended to breed. And then obviously because it was dangerous for the patients. So what you have to take home from this is that we need breed screening. It's imperative, it's necessary for 2 reasons. For patients that are going to be breeding, obviously, please, before they get pregnant, because a lot of times they come in, she just had a litter, and in order to give them away, we need an echo to say that she doesn't have HCM, and then boom, she has other things. So before getting pregnant, please do screening. And then also for not breeding animals is for the patient's health. So in this case, probably not going to give her a lot of problems. We're going to do some rechecks over time, but again, very, very important to do screening. So thank you very much. And I'm going to stop this share. Let me see here. Okay.
Okay, Sarah, thank you. While we are waiting for the video, I would like to remind you that after the video, please don't leave the meeting, because we will organize the question and answer section. And after that, I will give you some information about the next ultrasound webinar. Okay, Sarah, if you are ready.
I am ready, let's say.
Okay.
Okay, good. So in this video, we try. I don't know if you were also in the other webinar. We tried our best to do a good job of taking an image that you could see how I was putting the probe, how I was positioned the probe within the animal, and also seeing the image in the ultra machine. Sorry if sometimes it moves a little bit. But I think the best thing is that you can see how I position the probe. So before I start the video, also I wanted to show you that I'm going to show you. I'm not going to be talking. I'm going to be talking right now. I'm not going to be talking in the video because obviously with the mask you couldn't hear it. But the ECG electrodes, I'm going to tell you that the red is going to be on the right side. So remember, red right RR. Then the yellow is going to be on the left side, and then the green one is going to be in the hind leg. When we're in this position, it's going to be always in the dorsal hind. When we switch positions, it's always going to be in the dorsal hind. These two don't change. So yellow is always in the left, right? The red is always in the right, but the green one, I switch it to the dorsal one. And this is my dog Google. So, okay, let's start. So I'm showing you here the red, the left, the yellow and the green. The marker is going to be towards the spine, dorsally, and we're going to do a 45-degree. I'm going to go underneath. I have a table here that is going to elevate the dog, so I can go underneath. And as you can see here, I get the image. I'll show you now better. So marker towards the spine. There we are. We have the right parasternal long axis. I'll show you right now. We can move a little bit, as I was saying before, we can rotate a little bit to get the maximum length of the ventricle right there. You can't see the ventricular outflow flow, so right there. Sorry, outflow tract. So I'm doing a video, I'm taking a video of that. And then I rotate it a little bit to take the 5-chamber view right there that I'm showing you the aorta, left ventricle, left atrium, right ventricle, and right atrium. So what I did, I'm going to show you now with the hair. I rotated a little bit, so from 12 o'clock to 11 o'clock without moving the transducer, just rotating a little bit. So I placed the collar Doppler. Let's see. I took a video of that, and I placed the collar Doppler. You can see that the area is switched in order to be long. And then I'm going to do the short axis. So we're starting like this, then like that, and then 90 degrees with the first one. And then we optimize by just fanning the tail. As you can see here, there we are. I'll get a better image. There we are. So we fan with the tail towards the spine in order to be right underneath the mitral valve. Right there. See, exactly, right there. You see the mitral valve moving? Right underneath is where you want to place the M mode. Okay, we bisected. So I was switching right now. I was increasing the gain in order to have a better image of all the walls. Right there. And I'm going to show you now. I moved to the mitral valve, and you're going to see right there that I'm showing you that is the mitral valve in order to do the EPSS. That I can show you here exactly. I'm sorry that you can't see very good, but we wanted to make sure that you saw also the probe. So I went over with the tail towards the sternum in order to get the heart base. So I'm starting from here, and then I tilted a little bit, and there we have aorta, left atrium. And then what I'm doing is I'm with the QRS, with the ECG, I'm going where the T wave is, right after T wave. I'm going to do the left aorta, left atrium aortic ratio. Okay, and you can see here, left article is right underneath here. So I always recommend to get at least 2 measurements, not to only stick with one, because that way you're gonna see, you're gonna have a more accurate one. So we stick with 2 or 3 or whatever you want. And then you can more or less see the cusps over there. So I'm measuring again. Right, and what I'm showing you here is that I draw an imaginary line because that was the vein. Okay, so in order to get the pulmonary vein, I'm going to show you what I did. So I rotated a little bit and then I moved the transducer towards the sternum. So I rotated a little bit, but then I moved the transducer towards the sternum. Sometimes you don't have to rotate. I just did it in order to get like a better image. You'll see once you get the image if you have to rotate a little bit or not. I placed the collar Doppler. I had a little bit of insufficiency right there. And then, as you can see, it's pretty much aligned, but I have to move a little bit the angle right there. And we have a laminar flow that is pretty rounded. Sorry for that, for that movement. Then we look at the right main pulmonary artery and the left one. I'll always take a look at those. And what I did is exactly, I lifted a little bit in order to show them a little bit better. So I start with that and I lifted them a little bit just to see them. Okay, now we're gonna do the subcostal. So the marker is gonna be towards the spine and I'm gonna go underneath. This is the diaphragm, this is the liver. Here I needed a little more gel and more alcohol, so please be patient. I'll show you now what it was. Obviously it was a little bit dry, so I wasn't getting a good image. So marker towards the spine, and we go from underneath. So liver, diaphragm, and I'm moving a little so you can see. So what happened with Hugo is that he didn't eat, but he had a lot of gas, so I wasn't able to actually see. And that happens, that sometimes happens. You can see the left atrium right here, but I was trying, you could see there's a lot of gas, so I wasn't able to do it. So now we switch to the left side, put the ECG, and we're gonna place the marker towards the spine, so right there. Okay, we do a 3rd-degree angle, and as you can see, right there. So what I did is exactly the 3rd-degree angle. Right there, we have a very straight and parallel long axis. Okay, took a video, then I go with the Doppler to make sure that there's no regurgitation. Okay, then I go with the pulsated wave to the tips, place it where the tips are, and I go with the pulsated wave. You're gonna see it right there. You're gonna have to put the line, the baseline, so like at the bottom, so you can see everything. What I was trying to do there, and then it took me a little longer that time, but I always turn down the audio because a lot of dogs get very nervous when they hear it. So E wave, A wave plays with the QRS and the T wave. It was a normal pattern. And then what I did is for the tricuspid valve, so I'm going to show you what I did. So I tilt the tail towards the spine. And again, in this case, I didn't need to go one intercostal space cranial. Sometimes you have to, sometimes you don't. But the most important is that you put the tail towards the spine. There was no regurgitation. And now I did in this case, I did it in a different order, but I rotated the liver from the apical view. I rotated the liver to see the aorta right there. So I also, oh, that's another thing. In order to align it better, I probably forgot to tell you before. So in order to align it better, I'm going to stop it. In order to align it better, what you do is you also tilt the tail a little bit towards the sternum in order to align it a little bit better. So I place the pulsated wave. And we get the sharp image of the aortic flow. And then we do the color wave. We see if there's any insufficiencies, which there weren't. And that's about it. Okay. So, Mauricio.